And I'd like to welcome everybody to the All-Party Parliamentary Group on Health in All Policies. For those of you that aren't aware of this particular APPG, this group is about investigating the health impacts of public policy, and particularly in terms of the impacts on health inequalities, both in terms of the socioeconomic distribution, but also in terms of the distribution on people with protected characteristics as well. What we are doing today, however, is we're not looking specifically at any one policy. We decided as a group at our APPG AGM that we would look at, or invite rather, some experts in the field to give their views on where we're going with health inequalities. What's happening? We haven't had the opportunity to question the experts in recent months, so this is an opportunity now to do just that. And I'm absolutely delighted to welcome such a fantastic panel. And to welcome Professor Sir Michael Marmot from UCL. Professor Marmot probably needs no introduction. No, I remember Professor Marmot as a public health trainee when he was working on the Whitehall studies. That's how long ago it was. But in terms of his work on social determinants of health and various other publications, but probably, Michael, you're going to be talking about the Marmot Review, and particularly the 10-year review that you published back in 2020, and where we've gone from that. I'm also very pleased to welcome Professor David Taylor Robinson. David is Professor of Public Health and Policy at the University of Liverpool, but also Professor of Child Health at the University of Copenhagen. And as a former University of Liverpool colleague, it's lovely to see you here today. And Clare Bambra is Professor of Public Health at the Faculty of Medical Sciences at Newcastle University. Now, again, Clare, I also need to say and raise this, that you were also at the University of Liverpool at the same time that I was at, but it's lovely to see you, Clare. And Clare's going to be looking at the inequalities within the North. And finally, but not least by any means, is Professor Kate Ardern. Kate and I also go back a long way. And when Kate was, I think you were a consultant of public health when we first met back in Liverpool. And Kate really did so much around health impact assessment at the time. And this is obviously a really important tool for public policy to explore the health impacts and health inequality impacts of public policy. Kate is currently Director of Public Health at Wigan, but she also had the very important role of being the lead Director of Public Health for Greater Manchester Combined Authority during the pandemic. Ongoing, I have to say, we mustn't think that the pandemic is over, with the responsibility for health protection and emergency planning and response. But Kate is going to be not just talking about health inequalities at a sub-regional level, but also in terms of what you have done in Wigan, which is quite, you are bucking the trend in Wigan there. So very much looking forward to seeing what you're doing there. So you each have 10 minutes, and we're going to start with Michael, if that's okay. Michael, over to you.
Thank you, and it's a pleasure to be doing this. Going back first to 2010, I produced the Marmot Review, Fair Society, Healthy Lives, and we laid out 6 domains of recommendations that related to our understanding of the causes of health inequalities and what needed to be done to address them. Early child development, education and lifelong learning, employment and working conditions, having enough money, the minimum necessary to lead a healthy life. The 5th was healthy and sustainable places and communities, And the sixth was taking a social determinants approach to prevention. In February 2020, on the 10-year anniversary of Fair Society, Healthy Lives, we published Health Equity in England, the Marmot Review 10 years on, and asked what had happened in the previous 10 years. It was bad news. Life expectancy, which had been increasing about 1 year every 4 years for a century. In 2010, there was a break in the curve, and the rate of improvement slowed dramatically. Second, there was an increase in inequalities. Health follows the social gradient. The greater the deprivation of the area, the shorter the life expectancy, and that gradient got steeper. And dramatically, what happened in the 10 years is that for the poorest people, life expectancy increased in London, but went down in virtually every region outside London. So 3 things: slowdown in health improvement. Second, increase in inequalities. Third, health for the poorest people got worse, for the poorest decile. And Claire, no doubt, will touch on this, that what we saw was that the social gradient in life expectancy was steeper in the Northeast and the Northwest than it was in London and the Southeast. If you look at Wales, Wales looks like England, only more so. Life expectancy in Wales is shorter than in England. The slowdown was marked over that decade from 2010 on, and the inequalities increased, and life expectancy for the poorest went down. So it was like England, only more so, worse off. Then came COVID, and it exposed and amplified what I've been talking about for fairly obvious reasons. And what was striking is that the social gradient in COVID mortality looked very similar to the social gradient in all-cause mortality. So we've got, one never knows when people talk rubbish, whether they're deliberately talking rubbish because they don't understand, or they're talking rubbish for some other reason. But the idea that now we've got the vaccine, that the pandemic is over, is rubbish. I mean, either, as one wag said, either they don't understand what pandemic is or they don't understand what over is. And the vaccine is very important, but to address the consequences of COVID-19, we have to address inequalities, because the inequalities in mortality from COVID-19, as I said, were very similar to the inequalities in all-cause mortality. And then we've had the most recent, I think yesterday, ONS published the most recent figures for England. And I'd been saying, so this is the triennium 2015 to 2017, and then 2018 to 2020. So it overlaps with the first year of the pandemic. And I'd been saying that life expectancy for the poorest decile went down. Now it's the poorest 4 deciles are going down. This is really, really shocking. Really, really shocking. And it's not only a COVID effect, because it was happening before COVID, but as I said, it's amplified by COVID. And for healthy life expectancy or disability-free life expectancy, it's pretty well going down for women and men across the whole spectrum. There's a decline in disability-free life expectancy. That doesn't mean the inequalities are over, because better off people are now also suffering. Poorer people are suffering more. But it shows the crisis we've got in health in this country. And it's not true of every other country. This is nowhere near inevitable. And all of that, of course, is before the cost of living crisis. Some of you will know, I was asked by The Guardian to give my thoughts on the likely impact of the cost of living crisis on the health and well-being of the poorest. And I thought a great deal about dignity, how undignified it is to have to resort to food banks to feed your children, to have to wear 2 overcoats indoors to stay warm, to have to plead with the landlord against eviction because you can't pay the rent, to have to cancel a children's birthday party because of cost. And leading an undignified life like that is very damaging to health and well-being, to mental health and to physical health. So we've got this absolute crisis, and it's going to get worse. And my starting point is that health tells us something terribly important about how well the society is meeting the needs of its members. And what we can say is that over the decade from 2010, society stopped meeting the needs of its members adequately because the improvement in health slowed markedly. And the inequalities in society increased because the inequalities in health increased markedly, and health for the poorest people got worse. And yesterday's publication from ONS show it's getting even worse. A lot of people say to me that they're totally gloomy about what's going on because we seem to have at our national level a set of politics that is not dealing with something so fundamental as health of the population and health inequalities. And indeed, it is possible to be gloomy. What keeps the gloom away from me is the work we're doing in local areas and regions. We published our Build Back Fairer report in Greater Manchester in June last year. We're putting the finishing touches on our report in Cheshire and Merseyside. Similarly, in Lancashire and South Cumbria, then North Cumbria said, why are you leaving us out? So it's now Lancashire and Cumbria. The mayor of the North of Tyne Combined Authority claimed he was working with us. And I thought I'd be delighted to work with them. I had to check with my colleague, are we really working with the North of Tyne Combined Authority? The answer is not yet, but the mayor thinks we are. So that's fine. Gateshead, the East London Foundation Trust, we're going to do work with London, with Luton, with Walthamstow, all around the country. Cities and regions are really interested. And now Gwent wants to be the first Marmot region in Wales. Coventry became a Marmot city right back in 2010. So this is really exciting. I painted a rather gloomy picture of what's happening to health nationally, and the evidence shows it is linked to policies of austerity. When we published our 10 years on report, I was suitably academically cautious. I've become less cautious as the evidence has grown stronger that it is linked to austerity. But it's really encouraging about the commitment in cities and regions really to make a difference. And eventually, when every area in the country is acting on the understanding of social determinants to create greater health equity, by golly, the national government will have to follow. Thank you.
so illuminating ears. I hadn't picked up on the figures that you mentioned yesterday. That really is very, very worrying. The poorest 4 deciles. That's absolutely shocking. It really is. Right, we're going to move on now to Professor Clare Bambra from Newcastle. And Clare, you're going to talk about your analysis from the North's perspective, given that we are in an age of levelling up.
Thank you. Could you just confirm you can see the slides, Debbie?
Yes, we can see them nicely clear. Thank you.
Okay, try not to be deaf by PowerPoint, but I like maps. My student liked maps, so I thought maybe the politicians will like maps as well. And some of what I'll be saying will be echoing what Michael's outlined, but obviously with more of a focus on the North and the North-South divide. I'll also touch upon some work that we've done with the APPG on left behind neighbourhoods. I'll outline in a bit more detail the data on inequalities in COVID and how that's impacted on the North. And then I'll touch upon the societal, but also the economic costs of health inequalities, and then think ahead to what this could mean in terms of levelling up. So as with Michael saying that the talk can be quite gloomy, but as with Michael, I also will try and have a more positive ending, but ultimately whether that ending is positive or not depends very much on you guys, on the politicians implementing and choosing to implement the right policies. So I won't go through all of this data, but you can just see very quickly that this is comparing the local authorities in the 3 northern regions, the Northern Powerhouse, for some of the key health outcomes and how that compares to the rest of England, just to demonstrate the extent of the North-South health divide. And obviously this is pre-COVID, and you can see, for example, that life expectancy for men and women is around 2 years lower, and then some of the major causes of death, such as cardiovascular disease, cancer, are higher. And then we can also see much higher prevalence of some of the big morbidity issues, such as diabetes and obesity. As Michael alluded to, the work out yesterday from the ONS shows that deprived areas, many of which are in the North, are falling further behind in terms of life expectancy and also in terms of healthy life expectancy. So Debbie, I think this is showing what Michael mentioned in terms of the falls in the most deprived 40% of neighbourhoods. Another feature for health within the North is that we have a very high number of what have been called the left behind neighbourhoods. So these are the most deprived wards in the country, but that also suffer from poor digital and transport connectivity and from a lack of public and cultural spaces. We did some work recently with the APPG looking at health inequalities in these areas, and you can see in the bar chart here that for left behind areas, the female life expectancy is worse than that of the rest of the country, and for male life expectancy, it's healthy life expectancy, it's also lower than in other not what are called non-left behind areas. So these left behind neighbourhoods have worse health even than other deprived neighbourhoods. There's kind of an extra kind of aspect of social exclusion that these areas are suffering from. Flicking on to talk about what's happened since in terms of the pandemic, then we've done some work with the Northern Health Science Alliance looking at the geographical and regional spread of mortality. And these maps show what Michael alluded to about the close relationship between all-cause mortality there on the right-hand map and COVID-19 mortality rates on the left-hand map. And we did some work comparing how was happening, particularly during the first year of the pandemic, so pre the real rollout of the vaccines. And we found that the mortality was around 12.4 deaths per 100,000 in the northern areas of the country, so 17% higher mortality rate for COVID in the north than compared to the rest of England. We've also explored what was happening with COVID in terms of left behind neighbourhoods, and we found that people in left behind neighbourhoods were 46% more likely to die of COVID than people in the rest of England during this first year of the pandemic. And there seems to be a kind of interaction between deprivation having a particular impact in the northern areas. So this chart here is showing that deprived areas in the north had a much higher COVID-19 mortality rate than equally deprived areas in the south of the country. And what you'll also see is that the affluent areas in the north and the affluent areas in the south are fairly comparable. So a lot of the northern question is to do with these very high amounts of deprived neighbourhoods, left behind neighbourhoods that we have within the north. Obviously, a lot of us working in the field are very committed to reducing health inequalities because of their cost to families, to the individuals in terms of lost life, and to society in terms of the loss of population. But it's also the case that there is also economic costs around health inequalities. And again, some work we did with the Northern Health Science Alliance calculated that the productivity gap, so in terms of economic production, there's a gap between the north and the south and northern and southern regions. And this amounts to around £4 per person per hour. And our calculations suggested that around 30% of this gap is due to differences in the prevalence of ill health in the northern regions. And we calculated that if the gap between the north and south in terms of ill health was closed, then it could produce an additional over 13 billion in GVA for the UK economy. Further, we can find that this economic cost is even more so when we look at left behind neighbourhoods, and that eradicating the health inequalities between these neighbourhoods and the rest of England could again generate significant amounts of money in terms of enabling people to participate not just in social life and to have better health, but also in terms of their economic participation. Obviously, this ties in very much to the conversations that the government is having and the legislation that's coming through around the levelling up. And we did some work that was commissioned by Public Health England, which looked at what could be done around levelling up health inequalities. And this very much draws on the body of work within the field, including Michael's reports that he mentioned. And we suggested that there could be 5 principles whereby we could go about levelling up health inequalities, closing the regional gaps both within the north and between the north and the rest of the country. And these vary from trying to make healthy choices the kind of easier choices, looking at long-term cross-sector multi-component action, having local design and local involvement in the policies that public health and other agencies deliver, targeting disadvantaged communities where needed, and matching the resources to the needs, so drawing on Michael's idea of proportionate universalism. And I think key within this is where we can learn from what's happened when a multifaceted strategy has happened. And we can look at this with regards to what happened in England from 2000 to 2010. And we can see that during this period when there was a national health inequality strategy, the inequalities between the more deprived local authorities and the rest of the country did decrease quite significantly. And this chart here with the dotted red line is looking at mortality amenable to healthcare. So this is where NHS can really help to prevent unnecessary deaths. And we can see that over the time period, the gap between the most and least deprived local authorities decreased. And this was probably as a result of the increased funding into the NHS and public health, which at the time was part of the NHS. This other chart, which I'm sure David will build on in his talk about what's happening to children at the moment. This looks at infant mortality rates again over the time period, this one going back to the 1980s, but through to the mid 2010s. And you can see that during the policy period, this grey box, that the gap between the more deprived and the average of English local authorities declined significantly, but then started to increase again after the strategy was abandoned and when other policy mechanisms such as austerity started to influence the life circumstances of mothers and young children. So been a bit of a quick tour there of some of the key issues in terms of what we've been looking at in the north. Obviously, the North-South health divide is very long-standing. However, there are ways in which it can be reduced. COVID-19 has exacerbated the inequalities between the North and the South, particularly when it comes to left behind neighbourhoods. These health inequalities are not just a northern problem, they cost all of society, and we can see that, for example, in terms of economic productivity costs. And in order to solve this, and I think what history and evidence suggests to us is that we do need to have a national health inequality strategy, and that this is needed to take targeted at different parts of the life course and across the different social determinants of health. It can't just be about the NHS or about behavioural factors. It also needs to take into account the huge pressing issues around income and cost of living and so forth. I'll just end there. Thank you.
Fantastic presentation there. Hold all your questions, everyone, and don't forget, if you're online, if you could put your questions in the chat, and we'll try and make sure that those are addressed during the Q&A at the end. We're going to move on now to David, Professor David Taylor Robinson. David, over to you.
Thanks. Thank you. Are we in business with the slide?
Yes, we are. Sorry, I muted us.
Yeah, great. So there's necessarily a little bit of repetition, and I'm going to focus on our Child of the North report. So I work in Liverpool in public health and lead a research team looking at the impact of policies on health inequalities. And we started our Child of the North report with this quote: "There's no keener revelation of a society's soul than the way it treats its children." And if you subscribe to this sentiment, then the report does paint a troubling picture of our nation's soul. So the Child of the North report we actually had a parliamentary launch in early March. It was put together by the Northern Health Science Alliance. Clare and colleagues were involved, and the N8. It was led by myself and Kate Pickett, involving 40 academics from across the North. And the report shows that kids in the North get a bad deal. It shows how the North-South divide in child health, which explains the North-South divide in adult health and thus economic productivity, was increasing pre-pandemic and has been made much worse by the pandemic, and it outlines what we might do about it. So we've already heard about the ONS, the latest data, but pre-pandemic, it's clear there was a crisis already. The large and persistent health inequalities were getting worse. So if you take the life expectancy of a child born in the most disadvantaged 10th of areas compared to the most affluent 10th of areas, I often use the contrast between Kensington, just around the corner from here in Liverpool, and Kensington in London. Then there's a gap now there's a gap of around 10 years in life expectancy, 20 years in healthy life expectancy. And as we've seen, those gaps have been increasing over time, and those inequalities have particularly hit women in the most disadvantaged areas. And we can say a number of things about these inequalities. There's nothing natural about them. They're a consequence of how we organize society. They're profoundly unjust, and they're also preventable. We know we can do something about them. They can change over time. We can do something about them through the organized efforts of society. And we know what causes them. By and large, the causes in the North or within Kensington, down south, are the same. They're due to differences in exposure to poverty, power, resources needed for health, differences in exposure to health damaging environments, protective health factors, and especially the conditions that give every child the best start in life. And as our Child of the North report shows, poverty is a major driver of the difference in health between kids in the North compared to the South. You can see there in the map the distribution of poverty. It's a major driver of inequalities, leading to worse physical, mental health outcomes, educational attainment, and lower lifelong economic productivity. let me just turn to a study that we've done recently that looks at children's experience in the UK of various adversities, including exposure to poverty. In this study, we used the Millennium Cohort Study, which is representative of children growing up in the UK. And we were able to characterize kids' long-term exposure to various things, including poverty, into adolescence. And these are the groups that emerge. We see 40% of kids in the UK low levels of adversity and poverty. A quarter of kids growing up persistently exposed to poverty. 12% of children persistently exposed to parental mental health problems. And there's a group of children, 10% of kids in the UK, exposed to both the combination of poverty and parental mental health problems. And then we go on to show the impact of these exposures on children's health outcomes, shown in this plot here. The plot shows how all of those adversities are really toxic for children's cognitive development, risk of obesity, risk of mental health problems. But we see this cluster here of kids exposed to both poverty and parental mental health problems. They're 6 times more likely to develop mental health problems themselves. And I think this particular cluster of adversity is an important focus for policy action. And in the Child of the North report, you can see the distribution of that cluster, persistent poverty and or parental mental health problems by region. So well over between 50 and 60% of kids in the North exposed to that very harmful exposure for subsequent health outcomes. And to be clear, it's the accumulation and clustering of multiple risks associated with poverty that's the particularly pathogenic aspect of childhood poverty, and it's the clustering and density of these causes that's greater in the North compared to the South that generally explains inequalities. So for kids growing up in poverty compared to those that are not, their homes are more crowded, noisier, lower quality, roads, neighbourhoods they live in are more dangerous, and they're more exposed to adversity. We know that children are more exposed to family turmoil, risk of violence, separation from their families. And recent research coming out in the Lancet in the next few weeks has shown how using the natural experiment of changing levels of poverty over time, we show that the stress associated with poverty is a major driver in England of children entering the care system. We calculate that almost 10% of care entries between 2015 and 2020 driven by rising child poverty at huge cost to local authority and public budgets. The report highlights, as we've heard, how even before the pandemic, lopsided policy choices, particularly those implemented under the banner of austerity, made the situation worse. The burden of cuts falling on disadvantaged rather than affluent areas, on the North rather than the South, and on vulnerable groups, particularly children. And then came the pandemic, and clearly we were not all in it together. As Claire showed, death rates, mental health problems, the economic shock was greater in the North compared to the South. And so, as our report shows, kids in the North of England spent more time in lockdown in more difficult circumstances. They had to cope with worse digital access. They were exposed to more toxic stress, to more disruption of protective services in health, education, and social care. All of these services stretched pre-pandemic. We've seen that children in the North had less digital access, less homework, less support. So the attainment gap, we know, has widened. One of the focus of the levelling up policy to reduce differences in children's educational outcomes. And the pandemic has supercharged inequalities in child health. So if you take the modern epidemics of childhood, mental health problems and obesity, this analysis shows levels of probable mental health problems in kids in 2017 by deprivation quintile, and in 2020. You can see the absolute level has increased dramatically, and the absolute inequalities have increased dramatically. And likewise with obesity, this shows obesity in 5-year-old kids. It's the proportion of percentage of children age 5 who are obese as they enter reception age. And you can see that pre-pandemic inequalities were gradually increasing, and they've dramatically increased since. So prevalence of obesity in kids has doubled, inequalities have also doubled. So what do we need to do to tackle the crisis? Well, to begin with, we must reduce child poverty and back a social security system that ensures an adequate quality of life for all children, and this must begin with sufficient income support. This is what the UN said about poverty in the UK. And here's the latest data on poverty that came out not long ago. By any measure, pre-pandemic, children in disadvantaged areas of the country were moving into poverty. And we've looked at the impact of that on numerous health outcomes, including mortality in children. But there's been a drop. You can see that there's been a drop in the latest data. And the drop's been steeper in the most disadvantaged areas. And that is partially the fact that median incomes have dropped as a result of the pandemic, but it's also the effect of the government's £20 universal credit uplift, which clearly shielded some children from the economic costs of the pandemic and lifted some kids out of poverty. But as we know, the UC uplift was cut, and we'll see the health impacts of that subsequently. Our modelling has suggested this will likely lead to an extra 1,500 children per year entering care. As Claire alluded to, the financial costs of inequalities, financial costs of child poverty are vast. This cross-party report from the US, which informed their levelling up strategy, the American Rescue Plan, estimated that the cost of child poverty is $1 trillion per year, so a 20th of GDP in the US. Rising child poverty and the high levels of child poverty we see in the UK should concern anybody who cares about our economy. And then, as we've already heard, in order to address the problem, we need to focus on address the consequences of poverty. So we need a fresh commitment to proportionate universalism. So services for everyone, but at a scale and intensity that's proportionate to level of need. We need to do the opposite of what you see in this plot. This plot shows what's happened to spending on preventative services for children over the last 10 years. So critically, we must guard against a new round of cuts to children's services as we move forward. And thirdly, we must develop an integrated cross-sectoral approach to addressing health inequalities. I'd argue that puts children's well-being at the heart of all policy. This will involve monitoring and evaluation of new policies for their health impacts. Our report talks about children's rights and taking a child rights-based approach in line with the UN Convention on the Rights of the Child, and shows data how the UK ranks poorly in terms of protecting children's rights. The UN suggested we have fiscal and welfare policies that have disproportionately disadvantaged younger generations. And finally, you know, what keeps me going is these are some of the young people we brought from Liverpool and from our Young Persons Advisory Group when we launched the report. Our kids in the North, we know that to be Northern is to be blessed, and that kids in the North have this amazing developmental potential, and all we need to do is provide the right conditions to let them flourish. And I would argue that this is the real meaning of levelling up, and these kids are the Northern powerhouse waiting to be levelled up. Thanks very much.
Fantastic, David. Thank you very much for that. Again, the figures that you're just mentioning around the impact of child poverty and looked after children. I mean, that is quite shocking. So I'm going to move on now, if I may, to welcome Professor Kate Ardern. Kate, lovely to see you. Over to you.
Thank you very much, and thank you very much indeed for inviting me to speak and present some of the story that we have in Greater Manchester and in Wigan. And I'll start with Wigan, if I may, if only because what we have been trying to do in Wigan, really since 2010, and since a very inspirational meeting that I attended, where Michael presented Fairer Society, Healthy Lives, his interim report, what we've been trying to do in Wigan is to put Marmot into practice and to show that it actually does work when you take a whole societal, whole system approach to addressing health inequalities and turning around some really bad figures. I first became Director of Public Health in Wigan in 2008, and every single statistic in 2008 was going in the wrong direction. Hopefully I'm going to demonstrate that things have changed quite considerably and have changed within a relatively short space of time as well. Wigan's part of the Greater Manchester system, and of course Greater Manchester, uniquely in England, has health and social care devolution. And I guess an observation from me, geography really matters, whether it's physical geography, social geography, the infrastructure and connectivity of a region, but also the, if you like, the organisational geography as well, and how organisations work together. And Greater Manchester, the 10 boroughs of Greater Manchester, all have an equal voice. We obviously do have an elected mayor as well, who in a sense is the 11th council leader, as opposed to an executive mayor. And that means that the boroughs work together and try to harness what we call the power of the 10. It means that the relationship between local government and the NHS, for example, is very, very collaborative and has been very collaborative for a number of years. So in other words, it's very much a joined up approach to health inequalities. And I think one of the the excellent examples of that was Greater Manchester obviously commissioning Michael to do Building Back Fairer in Greater Manchester, alongside another commission report looking very specifically at race and health, the Inequalities Commission. And what we are doing now is obviously building all of those recommendations back into both Greater Manchester's COVID recovery plan, living safely and fairly with COVID, but also into our locality plans within the development of the integrated care system in Greater Manchester. Why is Wigan a little bit different? Well, Wigan is right on the western edge of Greater Manchester, and one of the things, the observations I made about geography is that social geography and who you interact with and who you socialise with is incredibly important. And I think very much laid bare by the experience of COVID. So if you look at things like our experience of COVID transmission, indeed our experience of mortality and morbidity in Wigan, it's very much mirrored what goes on in St Helens, in South Lancashire and Warrington, or as I like to call them, the rugby league boroughs, because actually that's who we socialise with. We don't socialise with the chair's borough of Oldham so much. And that's down to our infrastructure geography, because it's very difficult to get west-east across Greater Manchester. We're not on Metrolink. It takes up to an hour on the very slow train to get from Wigan into the centre of Manchester. So people do not commute for jobs. They don't commute for work because it's difficult to do so. Now, that was actually quite protective during COVID, because it actually meant we tended to stay within our communities and neighbourhoods as opposed to having to commute out. But obviously that's more difficult when you think about where jobs might be placed or where the economic opportunities are to tackle health inequalities. The Wigan deal, therefore, came about as a response to austerity in 2010. There is an excellent report from the King's Fund, which is on the King's Fund website, and indeed a whole page dedicated to Wigan. What was that about? Well, if we have less resources, we can go down that kind of salami slicing, cutting things. And guess what? As David presented, the first thing that often gets cut when money gets tight is the prevention. We did the opposite in Wigan. We decided to actually look at the behaviours of ourselves as a council. We often talk about behaviour change in the public, but actually it's how we operate as organisations, how society operates, and that engagement with citizens that's really important. And I guess it harks back to some earlier research that Michael did, the Whitehall studies, about looking at who actually experiences heart disease most often. And it's those who have least agency, least control in their lives who actually experience the worst mortality from CBD. It's not high pressure, high stressed professionals. So what we did was to re-engineer a new relationship. We call it the deal. And it's a new relationship between public services, citizens, communities, and I think, Michael, you'll be delighted to hear this, businesses as well. This is about do with, not to. In other words, it's about actually getting out and having those kind of really grown-up conversations with citizens, and also investing in citizens' ideas. We've invested over £11 million in citizens' ideas, all linked to things like health outcomes as well, but based on citizen creativity. It's also about recognising that people have strengths and assets, giving people, if you like, confidence in their own skills and assets, really important. Sometimes as professionals, and I know this as a doctor, I'm trained to diagnose and treat. Sometimes that's about disempowering people. I look for the problem. This is about recognising that people actually have strengths and supporting them and investing in those strengths, really important. So one of the things we did was to work with an anthropologist, an ethnographer, and one of the things I would say that perhaps the NHS could do with is a chief anthropologist to actually understand how to work with people and how to actually deliver the best for people rather than doing to them. We also recognise that place is very important, that sense of neighbourhood, that sense of community. Some of our borough in Wigan goes back, it's mentioned in Doomsday, and we tend to impose geographies that suit organisations. What we did very carefully was to organise our services, and that's not just in the council, but with the NHS, with the primary care networks, and of course, across the voluntary sector, the police, the fire, around 30 to 50,000 populations, which are our historical neighbourhoods. And to think about these in terms of anchor institutions. Now, often when you hear that term, you hear it referred to in terms of hospitals in the NHS. Actually, our anchor institutions are those organisations in the community that have registered populations, our GPs and our schools. So one of the ways in which we are trying to tackle the inequalities agenda and that best start in life was to bring schools, GPs and head teachers together. They see the whole family, but often they haven't been talking to each other. Bring them together, actually invest in their time and their resources around that best start in life for children. And then really focusing, I guess, on creating a collective narrative for the place. Very important, not just to have the statistics, although they are clearly important, but to actually tell people's story and give them the opportunity to describe their pride in place. It's amazing what you can do when you start to invest in people themselves and people's own ideas about what's best for the place, and not impose, if you like, a professional or indeed perhaps a perspective that doesn't understand the place. Really develop leadership within a place-based structure. We found that we were able to pivot that kind of response when COVID hit from a health improvement approach to a health protection approach, and it's worked incredibly well. It's also about investing in very local jobs and very local businesses. So our economy is mostly SMEs. We don't have a university physically on patch, and actually that was an issue in terms of retaining our really good and talented young people. So we've gone into a formal partnership as a council with Edge Hill University, a new medical school. So again, about really investing in creating highly skilled jobs that are very local. So you start to retain and invest in your local economy. This is community wealth building, if you like, is really at the heart of what we're trying to do. So I guess the sort of observation I would make, this kind of story is going on in different ways across Greater Manchester. It is not a one-size-fits-all. What works in Wigan would not necessarily work elsewhere. And indeed, that's why understanding the history, the geography and the traditions and what motivates people, what motivates your citizens is really incredibly important. Does it work? Well, I'll end, if I may, with I think a very telling statistic, and this is from our Healthy Life Expectancy 2021 update. Wigan is the only borough of our statistical neighbours where the healthy life expectancy for both men and women is over 60 years. For our other statistical neighbours, they are below 60 years. Wigan is now not statistically different from England in terms of its healthy life expectancy. It was significantly worse over 10 years ago. And whilst England, of course, as we've heard, is of course declining in terms of its healthy life expectancy for women and only marginally increasing or static for men, we are still increasing at a significant rate for both men and women. So I think, in a sense, what we're demonstrating is where you invest in prevention, where you invest in your community, and where you take a whole societal, whole system, asset-based approach in the way that Fairer Society Healthy Lives really emphasises, it can actually work, even when you've got a pandemic and when you've had significant impacts in terms of austerity. Of course, cost of living and further challenges to the economy could, of course, knock back that progress. And that is perhaps something we are concerned about, but trying to mitigate as best we can. Thank you.
Well done, Kate. Thank you so much. And the point that I take from that was in terms of, as you absolutely say, it's around locality, it's around geography, but also it's not just what you do, it's how you do it, and the engagement of people in service delivery and so on is so important, and prioritising around that as well. Right, we have about 35 minutes for questions. Peter, you're right up there. Go on.
Peter Bottomley. I first got involved in this when my wife was doing long-term research with the Child Poverty Action Group in the early 1970s. When Margaret Wynne was talking about the importance of the condition of fathers and mothers at conception, whether they smoked, whether they drank, how prepared they were, the relevance of the age of a mother at birth, low birth weight type things. Then I got involved in big public health things, in part when I was responsible for road casualties, where we cut the road casualties by 2/3 without any change of law, sensible enforcement, not by increasing safety, by reducing risk. And my understanding from the 2015 report is that half the difference in life expectancy is down to the circulatory, the respiratory, and the cancers. I haven't heard much in today's presentations on those. By the way, for the last report on Wigan, I do strongly believe in what William Temple called the small platoons, the intermediate groups, and things people may think about themselves. We may be involved in big public health things. Individuals also have the local groups they can talk about as well. But my key point, I think, now is what advice do we give to people before conception? And secondly, in these presentations, is it right to ignore the circulatory, the respiratory, and the cancers?
Thank you, Peter. We'll take 3 at a time, if that's all right. So you can make a note of that. Have we got any other questions, either from our group here or from anybody online?
I was very touched by what Michael said about the nation's health and the outcomes of our health being related to how well we are doing as a country. I think that, to step back from, I think Keith's point on the specific and the physiological is very important, but then at the other side is this sort of holistic approach. But all we've heard about is poverty. There are other things that are drivers of happiness, and one sense of community, one sense of family, one sense of education, of place and nationhood, one sense of aspiration and moving forward in life. These are all really important drivers of one sense of well-being. What role do you, I'm really questioning for Michael, what role do you think those things play? And is the fact that our obesity and our ultimate longevity outcomes proving to be so poor related to the fact that there might be a big problem at the heart of the country's well-being? Are we a country in a state of trauma, is I guess my question.
And the third question, who's going to, either from our virtual participants or from the room? Okay, well, I will put one if nobody's. The third one I'd like to ask is in terms of status and the impact. I know both Michael and I think David mentioned it as well in terms of power, and it slightly links to what Kate was saying as well. So we know a lot about the inequalities in income and wealth and the impact that they have on our health, but we haven't really explored in the same detail about the impact of status and relative power. And if you're able to say something in relation to that. So you've got your three questions. Who wants to kick off?
Well, I'll start. I couldn't hear very distinctly, so I'll answer the bits I could hear, and forgive me if I don't answer the other bits. It's not only poverty. One has to have a conceptual framework, and our conceptual framework does start with inequities in power, money, and resources. Not just money. Secondly, the social gradient means that people in the middle who are not poor by any means have shorter life expectancy and shorter healthy life expectancy. If the gap for healthy life expectancy is around 17 years between most and least deprived, people in the middle have about 8.5 fewer years of healthy life expectancy. So that's not poverty we're talking about. It's relative disadvantage, but not poverty. And in my 6 domains, one was having enough money to lead a healthy life, but the other 5 were giving every child the best start in life, education and lifelong learning, employment and working conditions, having enough money, but healthy and sustainable places in which to live and work, and taking what I call a social determinants approach to prevention. And your question about aspirations, I think aspirations are vital, but aspirations aren't all that helpful if you are growing up in dire poverty. We know that. That's what the evidence shows. I've used, probably overused, the example of healthy eating. People in the bottom 10% of household income, to follow the healthy eating advice, would have to spend 74% of household income on food. And people have asked me, where is social personal responsibility in all this? And I say personal responsibility is vital. If rich people give Coca-Cola to their children, they're being irresponsible. It's up to them. It's not up to me if they want to be irresponsible. But if poor people give inadequate food to their children, they're not being irresponsible, they're being poor. So yes, poverty is important, but it's not only poverty, it's these other domains. And I think the other issues to which you refer are absolutely vital. A sense of agency, leading a life of dignity, having aspirations, wanting better for you and your children, for the next generation, are all absolutely vital. But the opportunity to fulfill those aspirations is most unequally distributed. And that's our challenge.
Thank you, Michael. Who wants to go next?
I guess I could comment specifically on the poverty issue. I mean, in terms of a conceptual model, as Michael has outlined, the socioeconomic position or the socioeconomic circumstances into which a child is born, and we can measure that in our studies on the basis of income or parental education level or occupational social class of the family or index of multiple deprivation. We know that those circumstances structure, cause exposure to a whole range of adversities and factors that protect health. And the reason a lot of my work focuses on child poverty is because that's one of the few things that we can change. It's clearly easy, as we've seen with the universal credit uplift, we can easily make a dent on levels of child poverty. We've done some work in using Danish linked data, because in Denmark you can look at the whole population and look at the circumstances in which children are born, and then follow them up, follow the whole population up and look at health in adulthood. And in a series of 3 studies that we've done, we show that indeed children that are born in socially disadvantaged circumstances, they have higher rates of exposure to the type of things that the gentleman outlined to begin with, low birth weight, risk of poor early child development, risk of preterm birth, smoking in pregnancy, etc. They're also more exposed to adverse family dynamics, toxic stress in the family, risk of separation from their family, mental health problems in the family. And they're also more exposed to shocks in early life, like death of a parent, death of a sibling, etc. And then we looked at the impact of that on survival into adulthood. And we show in the analysis that even kids transiently exposed to poverty are more likely to die in early adulthood. And what were the causes? What the causes of death in that study were things like suicide, but also cancers and accidents. And I guess we know from the life course perspective that these early adversities and exposures that are related to levels of child poverty translate into the adult risk factors that we know are important. And in our third analysis using that data set, we showed that half of the inequality in mortality in adulthood in Denmark is explained by those childhood adversities. So there's a lot of focus on the adult risk factors, but those adult risk factors are upstream. They follow on from children's exposure to adversity. So I would argue that in order to improve health in the population, we need more of a focus on children's health and their early years experiences if we're going to be able to do something about it. Is our country in a sense of trauma? Well, we've got the highest under 5 mortality in Western Europe, and it's related to levels of child poverty. The US in OECD countries has almost the highest level of under 5 mortality. The UK is the European highest, and we're clearly lagging behind when it comes to league tables of children's health. And if you subscribe to the idea that children's health is a good litmus test of how we're doing as a society, we're not doing very well. And that doesn't come down to children. You can't blame that on children's aspirations or them not having any get up and go. Kids are born with all of that potential. What we're seeing is the impact of socioeconomic conditions on, really disadvantaging a big chunk of kids, especially in areas like Liverpool and in the north of England, early on in life. And if we want to level up, we need to do something about that.
Thank you, David. Claire, Kate, do you want to add to that?
If I may, I'll talk about cardiovascular disease and answer some of the question there. The whole sort of public health programme in Wigan is actually called Heart of Wigan, and it is actually based on the North Karelia Finnish model of CVD prevention, which is a whole system, whole societal approach. Very interesting. North Karelia had some of the worst statistics in terms of heart disease in the late 70s. And this was very much a grassroots movement for change, the citizens going to the regional government and saying, you know, too many of us are dying of heart disease, what do we do about it? Interestingly, they were spending a lot of money on heart disease, but it was all in the high specialist treatment end of the system and not on prevention. And it was a very similar picture when I went to Wigan. The commonest cause of preventable premature death in adults in the borough is heart disease, as it is in England. So what we did was to adopt the North Karelia model. We shifted investment into the prevention side. We also adopted measures and interventions that actually enable citizens to gain control. So we adopted Heart Start from Seattle, which is around teaching people to do resus. We adopted that in our schools. So we were teaching kids from the age of 7, 8 to do cardiopulmonary resus, but also linking that with knowledge about how to prevent heart disease. So, I've got 7 and 8-year-olds who are really, really knowledgeable about health improvement when it comes to heart disease. We also link that to the Royal Society of Public Health Level 2 Health Improvement Qualification, a GCSE level qualification open to all adults, which developed into a set of heart champions, really good in terms of developing confidence, but also opening some job opportunities to people as well in terms of entry-level qualifications for health, and link that with community defib rollout and NHS health checks, but also targeting our NHS health checks and our health improvement and health champion training right into our SMEs, into those folks who will never rock up at the GPs, i.e. mostly, I'm sorry guys, middle-aged men who don't like going to see the GP or will only rock up in healthcare when they absolutely have to. And has that worked? Well, we now have a health movement for change across the borough, which totals 23,000 citizens, which is amazing. Have we made progress in terms of CVD? Those healthy life expectancies improvements that I was quoting to you earlier are down to the reduction in both CVD and lung cancer mortality and morbidity. So we've reduced early deaths attributable to CVD in the borough by 29% for men and 25% for women. Similarly, our early deaths for cancer are now not significantly different from the England average, and our smoking rates, you'll be pleased to know, in a former mining borough, in terms of routine and manual class, are now at 22.8%. So that for routine and manual class, that is the lowest in Greater Manchester and 3% lower than the England average. So in other words, the focus on focusing on CVD and doing it in a whole system way not only impacts on CVD, it also impacts on cancer. It can also impact, hopefully, on your alcohol and your obesity levels. And of course, very importantly, in a longer term impact, if you're really focusing on CVD prevention, you also reduce people's risk of vascular risk dementia as well. And in the fastest growing older population in Greater Manchester, that is obviously quite an important thing to focus on. Thank you.
Thanks, Kate. Excellent. Claire, did you want to say, I'm just conscious of time and just to give others a chance to ask questions. Do you want to comment on no? Okay.
Yeah, just
Michael, do you want to quickly?
So just following up from what David said, the question, are we in a state of national trauma? I can't answer that directly, but what I can say is that the slowdown in improvement in life expectancy in the decade 2010 to 2020, the slowdown in the UK was more marked than in any other rich country except Iceland and the United States. If we look at child poverty among the 38 OECD countries, we're higher than the average. Among the rich countries that worse than us is the United States, just below Mexico. If we look at spending on early childhood, we're lower than the OECD average. The only big country worse than us is the United States. If we look at child well-being, among 38 countries, we rank 27th, one being the best. The US ranks 36th. So on virtually, I'm echoing what David said, on virtually every index I look at, whether it's actually investment in social programs or outcomes like child poverty or health, we're doing badly.
Yes.
We're doing badly. We're lagging behind the average of the rich countries. I personally don't think we should be comfortable with that.
No.
We shouldn't be also rans. We should be, I think, what's the phrase we keep hearing? World beating. I don't want to be world beating. I just like to be good.
Thank you so much, Michael. I think everybody would agree with you that's here. I know Ali has a question. Does anybody else have a question? Mary?
Comment slash question that you. I think Kate is a mind reader, because my question was going to be, could somebody give me an example of really good prevention? And was it that so thank you for preempting me, Kate. But just to develop that point, I'm really interested in any thoughts on where we should be paying attention, particularly on this, on this point of heart health and lung health, on broader policy areas, like, for example, public transport or the world of work, or what are the best examples of where, if we think about health really broadly, we can actually make a big impact rather than continually expecting the NHS to do everything.
Okay, don't answer those yet. Mary, do you want to ask your question?
It was actually, I guess, comment. I've been in the role with public health for a while with my work at Gateshead Council, where we have a fantastic director of public health there that Michael knows very well. I'm sure you all do as well. And I guess for me, I know a lot of us understand the social determinants of health and what the issues were and what the causes are, that it's the same socio-economic groups that will be affected by all of these issues. However, I guess for me, it's the frustration of then the lack of any action from government. Is in terms of what today I led a debate on tobacco control. We were promised a green paper on tobacco control. We know tobacco causes half the deaths in the North East, and there's no action there. We know that we've heard that there'll be more children born into care. There's a lack of foster carers. We know that a decent job, a decent income, and will have one of the biggest impacts on a healthy life. And yet, all of those little, I just don't understand what can we do as politicians to convince the government that it's not just the right thing to do, but it's also good for the country. It's good in terms of NHS budgets, in terms of health and social care budgets,
all the figures around productivity.
Productivity in areas where there's high smoking rates is unbelievable. But it's very frustrating trying to convince the Treasury, I guess, that the prevention agenda is.
We've got some colleagues, certainly Peter, I saw George Young on before, so there are lots of colleagues hopefully. But we've got two more questions that I want to get in, and if you could consider those in your responses as well. I know Pfizer has asked about what, in terms of the health inequality strategy, what that would mean in practice, and she refers to the health inequality strategy in Greater Manchester. There was another question as well in terms of, does the panel think the white paper on health disparities, why call it health disparities? Why isn't it health will have a positive impact if no new funding is attached to it? Anything else? Is this from you, Peter?
Yeah, sorry. Before Marmot, Richard Wilkinson wrote to David Ennals in about 1977, sometime, which led to the Sir Douglas Black's report coming out.
Yeah.
A fewer than 300 copies were printed,
Yeah.
and it's all available at Socialist Health, is basically what I'm saying,
Yes.
with a very good introduction explaining Richard Wilkerson part. But also it says, and they say so, that the difference between the social gradient increased in the 30s and in the 40s and in the 50s as well. So we aren't seeing necessarily a short-term difference, it seems to be a trend.
Do you want to pick up on that quickly, Michael, in terms of, so Peter's saying that the social gradient was actually there in the 30s, 40s, 40s and 50s. And so is anything really changing? It's always been here and
increasing.
It's increasing.
As far as we know, the social gradient was there in the Victorian period as well. So I mean, William Farr was documenting something similar. So it's been there forever. But two things. Firstly, the health of the worst off is one marker of improvement. And the worst off, take infant mortality. In 1900, the worst off have an infant mortality of about 250 per 1,000 live births. And now it's about 6.5. So the worst off 6.5, I would say that's pretty good. So I wouldn't wring my hands and say, well, there's always a gradient. There's nothing we can do about it. The gap between the best off and the worst off is now about 3.5, whereas in 1900, it was more like 150. So we can make an enormous difference to improve the health of the worst off and narrow the gap in absolute terms. And that's very important, because it's not right to say, well, we've always had it, there's nothing we can do about it. And then the second thing to say is Clare demonstrated the slope of the gradient can change. It got shallower and it's getting steeper again. That's not unique to the UK. But for example, in Brazil, the gradient in infant mortality and in stunting in the first year of life got dramatically shallower, reduced enormously. So yes, we find gradients wherever we look, but the slope, the magnitude varies enormously, and the health of the worst off can improve enormously. So it's not a counsel of despair by any means. And again, to repeat, as Claire showed, it seemed to get shallower in 2000s, and it's been getting steeper again. And that should be cause for alarm.
Absolutely. Claire, do you want to come in here?
Yeah, thanks. And thanks, Michael. I wanted to just, I think it follows on, which is about the question that was in chat about the national strategy. And I think that follows on, because obviously myself and other colleagues, including Michael, have argued that that strategy was part of what made the difference in the 2000s. And the reason that I think we need one now, I think is probably self-evident from the fact that inequalities were reduced in that period. I think that there is good local action happening, like Kate gave the examples. There's also good examples across all parts of the country, all regions, but there are certain things that only national government can either implement, instigate or fund. They might be locally delivered, and I think indeed, you know, the 2000 strategy by no means perfect, and I think having stuff that is more locally bespoke and driven by local communities is certainly more likely to be effective and engaged with, I think, which I think is what Kate's examples have shown. Yes. So that's why I think a national strategy is needed. But then I wanted to just comment, I think, is it Mary Foy who's there?
Yes.
Yeah, hi Mary. I wanted to just come back on what Mary was saying about how can you convince the Treasury about the importance of health inequalities. And some of the work that I presented was talking about how we've estimated the cost to the economy of health inequalities. You know, the north-south divide in terms of economic productivity, we think is around 1/3 to do with high rates of poor health. And so the next step on that, if you were so inclined to Treasury colleagues, would be to say, if you have more people working because they're more able to, because their health has improved, then you will have more of a tax take and you'll have less to spend out in terms of the NHS and in terms of associated costs, be it welfare, be it children in care, etc. So I think there is a powerful economic argument. I only like to make it alongside the social justice and moral one together, but I'm not in the Treasury.
Anybody else? We've got about 10 minutes left.
I just wanted to chip in on social gradients. We've been looking at comparing the Millennium Cohort Study to the Danish National Birth Cohort Study and looking at gradients, inequalities gradients in parental mental health problems and children's mental health. And in the analysis, we have a much steeper gradient in child mental health and higher prevalence compared to Danish kids. And that's partly explained by the fact that parental mental health in Denmark has a very shallow social gradient compared to the gradient in the UK. So in the UK, we seem to have created a situation where being poor or being disadvantaged becomes rapidly very bad for your mental well-being, and in the study we show that that's part of the transmission to children and part of the intergenerational transfer of mental health problems. It's clear that these social gradients can vary dramatically across countries, and actually, if you look at the level of mental health problems, parental mental health problems in the most affluent in the UK and Denmark, they're the same. It's just that as you become incrementally more disadvantaged in the UK, parental mental health problems ramp up. And it's clear from what we're seeing with life expectancy in women that we seem to have designed a set of policies that's particularly harmful for women's life expectancy, for mental health, particularly in women, and that is having an impact on children. On good examples of prevention, we've done a number of analyses making use of the natural experiment of changing local government spending. So local government spending has changed different levels across the country, but also different sectors have been affected differently. So if you look at children's spend, it looks like it's gone up, but all of that increase is due to local authorities spending more on children going into the care system. So it's spending on failure, essentially. And we've shown that spending on youth preventative services prevents children ending up in the care system. We've also shown that spending on Sure Start impacts children's level and inequalities in obesity. So there are good examples where investment, which is cheap, prevents these really costly problems, children in care, obesity, mental health problems. These problems cast a long shadow over the whole of the rest of the population over the life course.
Somebody's muted us. We're not muted. Kate.
Kate.
Thank you. And I sort of just following on a theme, if you like. One of the reasons Greater Manchester was so keen to get health and social care devolution as part of its devolution package was when it looked at what was holding back our economy, it was long-term chronic ill health. And the only way in which we are going to thrive economically is to actually invest in preventative health that actually gets our workforce more economically active. And interestingly, I was talking to our borough director of finance, who always pulls my leg about having more older people in the borough. And I pointed out to him, yes, you do, Paul, but you've also got a lot more economically active people. In other words, the council tax take is higher because we've increased, if you like, the healthy life expectancy of the borough. Of course, it is not sexy to invest in prevention, is it? And the answer to Faizia's question, yes, we do need a national inequalities, and I'll definitely use the word inequalities strategy here, but it must be resourced, and that resource cannot be what I call micromanaged from Whitehall on what I call siloed projects. It's got to be investing in local systems and local communities with a significant devolution of control so that local areas can actually spend it in a way that's relevant to local people. And that has always been the challenge, I think. We also need to shift NHS funding and spend and pick up Derek Wanless's excellent recommendations when he talked about a fully engaged scenario back in the early 2000s. In other words, shift the NHS from an illness service into a prevention service. That is going to be an almighty challenge given the backlog of COVID elective recovery. And some examples of where local investment in prevention, active travel, food production, local food production, getting out into green space. One of the things we've also done is taken back our social housing under council control in Wigan so that we can target working with our housing tenants, really target health improvement, wraparound interventions, particularly targeted at families. And then working with our environmental health and trade standards colleagues, who also deserve a huge round of applause for what they do in terms of public health to tackle things like illicit tobacco supply. You've got to turn off supply as well as tackle demand. A few examples, thank you.
I'm waiting very patiently.
Yeah, and in talking to people about prevention, there's a tendency to focus too much on the individual and say, well, it's about getting people not to smoke and eat healthily and so on. Yes, each of us here, one way or another, has produced evidence on social determinants of health. If you want a very good government publication, look at the Levelling Up white paper. The analysis is brilliant. The 4 objectives, the 12 missions, it's excellent. If a government were to deliver on those 4 objectives and 12 missions, I'm no good at prediction, but I'm pretty confident that health would improve and health inequalities would diminish. It's not just about prevention, it's about creating better societies. The problem with the Levelling Up white paper is that the scale of resource so far devoted in no way matches the ambition embodied by those 4 objectives and 12 missions. So the analysis is all laid out. And it takes government to say, we're going to do something about this. From the north of the country, IPPR North said that the cuts per person from 2010 in local government was somewhere in excess of £400. So far, the Levelling Up budget per person is £33. So the analysis is brilliant. Now we need the political will to do something about it.
Right, that's a perfect place to end today's discussions, and I think all of us will want to take away from all the different parties that are represented here food for thought, and also to take back to their colleagues within the front benches. Can I start with some thank yous? Thank you so much, Michael, David, Kate, Claire. That's absolutely, you've been brilliant, so thorough in terms of both your presentations, but your responses as well. And it really has been so helpful for us. So thank you so much, giving up your time, spending all the time with your preparation as well. Very, very grateful to you. If it's possible, if you could circulate whatever presentations that you provided. I know there are lots of people that would like to see those. And we will be writing up a mini report from tonight. So hopefully that is another way that we can take forward the points that have been raised here as well. Very, very grateful to you, and thank you again. And thanks to all the participants as well. Thank you.